Welcome back, everyone. I'm Dr. Khan, and I am pumped for today. We are diving into the operating room to talk about mastectomies. Now, if you're a student, you might just see these as a list of structures to memorize, but think of it like this. The breast is a house sitting on a very complex foundation. When we perform a mastectomy, the question is, are we just moving the furniture out, or are we taking down the walls and the plumbing too? That's the difference between simple and radical.
That's a great way to frame it, Dr. Khan. I'm Dr. Sarah, and while the clinical side is exciting, the boards love to test the specific anatomical boundaries that separate a simple mastectomy from a radical one. For the exam, you have to be precise about what stays and what goes, especially regarding the pectoral muscles and the axillary lymph nodes. Let's start with the simple mastectomy, also known as a total mastectomy.
Right, a simple mastectomy is like the clean sweep. We're removing the entire breast tissue, the nipple, the areola, and the overlying skin. But, and this is a big clinical but, we are leaving the deeper structures alone. We aren't digging into the axilla and we aren't touching the muscles. Why does this matter clinically? Because if the cancer hasn't spread to the lymph nodes, we want to minimize the collateral damage to the patient's arm function and lymphatic drainage.
Exactly. High yield point here. In a simple mastectomy, you are removing the breast tissue down to the retromammary space, which is that loose connective tissue plane between the breast and the pectoralis major fascia. You might take some level 1 axillary nodes if they are suspicious, but generally the axilla remains intact. Now, compare that to the modified radical mastectomy. This is the most common one we see today.
Modified radical is where the plumbing comes into play. We take the breast tissue, the skin, and the nipple, but now we're heading into the armpit, the axilla. We're removing level 1 and level 2 lymph nodes. Think of the axilla as a pyramid. Dr. Sarah, how do the examiners like to define the levels of those nodes? Because that's a classic trap.
It is a total trap. Everything revolves around the pectoralis minor muscle. Level 1 nodes are lateral to the pec minor. Level 2 nodes are deep to the pec minor. Level 3 nodes are medial or superior to it. In a modified radical mastectomy, we typically clear level 1 and 2. Crucially, the pectoralis major muscle is preserved. We might remove the fascia covering it, but the muscle stays. And that preservation is huge for the patient. If I leave the pec major intact, the patient keeps their doctor of choice for physical therapy later because they still have the power to adduct and medially rotate their arm. But if we go old school and do a true radical mastectomy, the Halsted mastectomy, the pec major is gone. It's like taking the engine out of a car. The Halsted radical mastectomy is rare now, but it is high yield for anatomy exams. In a radical mastectomy, you remove everything: the breast, the skin, the nipple, both the pectoralis major and minor, and all 3 levels of axillary lymph nodes. You're essentially exposing the ribs and the serratus anterior. Man, that's a massive surgery. Why does this matter clinically? Well, if you're that deep in the axilla, you're playing in a very dangerous neighborhood. You have the axillary vein, the long thoracic nerve, and the thoracodorsal nerve right there. If I'm a surgeon and I accidentally snip the long thoracic nerve while clearing those nodes, what happens, Sarah? That leads to one of the most famous board questions of all time, the winged scapula. The long thoracic nerve innervate the serratus anterior, which holds the scapula against the rib cage. If that nerve is gone, the medial border of the scapula pokes out like a wing. You can test this by having the patient push against a wall. It's a classic sign of surgical complication.
And don't forget the lat pull nerve, the thoracodorsal. If that's damaged, the patient loses the ability to extend, adduct, and medially rotate the humerus. They can't pull themselves up or even reach back to scratch their own back. Clinically, protecting these nerves is just as important as removing the tumor. Let's recap the boundaries for the students listening. The axilla's boundaries are essential. The anterior wall is the pectoral muscles. The posterior wall is the subscapularis, caries major, and latissimus dorsi. The medial wall is the serratus anterior on the other ribs. The lateral wall is the bicipital groove of the humerus. When you're doing a radical procedure, you're navigating along these walls, trying to clear the fat and nodes while sparing the cables, the nerves and vessels. Great summary. It really comes down to the extent of the disease. If the cancer is confined, stay simple. If it's moved into the lymph nodes, we go modified. If it's invading the muscle itself, which is rare these days, we go radical. The goal is always the same: get the cancer out while keeping the patient as functional as possible.
Exactly. Just remember for your exams, simple is just breast tissue and skin. Modified radical adds level 1 and 2 nodes but saves the muscles. Radical takes the muscles in level 3 nodes. And watch out for that long thoracic nerve.
The takeaway? Anatomy isn't just a map. It's the guide that tells us where to stop cutting. Simple mastectomy spares the foundation of the chest, while radical mastectomy clears out the foundation to save the patient. Know your boundaries, know your nerve roots, C5, C6, C7 for the long thoracic, and you'll crush your rotations and your boards. Thanks for joining us.